Next speaker now, Professor Jan-Willem Alffenaar, and he's at the University of Sydney, and Professor Alffenaar is the Chair of Clinical Pharmacy. His research interests include investigating the use of anti-TB drugs, as well as the clinical application of therapeutic drug monitoring. He's developed implementation strategies for TDM in different settings, and he's here to discuss the use of microsampling in remote and rural settings. Thank you, Jan-Willem.
Thank you, Susie, for the kind invitation and opportunity to talk to you guys today. I'm going to talk about facilitating PK studies in remote and rural setting. And the first question that we actually need to address is whether it's PK or TDM. And you see in the background a horse and a dog running alongside. And although they're black and white, they are quite different. So with a PK study, we think of studies where we collect samples, analyze samples, and interpret data. But with TDM comes the additional aspect of doing it in a kind of real-time situation that allows you to make clinical decisions with potential implications for drug dosing. And to make it a little bit more confusing, if we go through literature, there's another kind of report that we will find, and that is the type of PK study based on TDM data. So they're evaluating routinely collected data, but of course, this is a kind of observational way of analyzing the data without the actual interventions. So why do we want to do these PK studies in remote settings? And the most important thing is, of course, that we already know that there is variability in the PK of drugs, and we know that these are potentially associated with treatment outcome or adverse effects. But the remote setting comes with interesting patient populations, comes with interesting diseases, but also comes with additional challenges. So typically we would use a setup like this to analyze our samples. But if we're talking about remote settings, this typically is not available on site. So what we would need to do is collect our samples and put them in the centrifuge, subsequently store them in the freezer, and then send them over to a laboratory to analyze the samples. However, if we're talking about real remote settings or rural settings, often they don't have the appropriate freezer, they don't have readily access to dry ice, or sometimes even don't have appropriate centrifuges. So in that case, PK studies become a challenge. So it's all about having the appropriate facilities to get your sample in appropriate conditions to store it until the analysis. So when going through literature and you're searching for these types of trials, I think there are very interesting examples of why we want to study PK in remote settings. And this is the first example that I would like to present, and it's about dried plasma, dried blood spots, and they're looking at the evaluation of nevirapine in HIV patients. And one of the benefits already discussed earlier during this evening is that with DBS, you have the opportunity to look at viral loads, you have the opportunity to look at genotypic drug resistance patterns, and of course, look at drug concentrations. And in this study, they looked at the differences in viral load, they looked at drug resistance, and they found that patients with low nevirapine levels had a higher risk of increased viral replication and drug resistance. So that there is a apparent clinical need to address this situation in these patients. And then interesting, in another publication from a different country, and they looked at actual implementation of TDM in these low resource setting using saliva and a very affordable thin layer chromatography setup. So real old school analysis of drug concentrations in saliva. Another example, also specifically related to remote situations and patient population, is this study where they looked at a different route of administration of an antimalarial drug, specifically intrarectal dosing, because in these situations, parenteral administration is not feasible, and they were interested to see whether their routes of administration resulted in adequate drug exposure to treat this disease. If we go through the method section of this paper, you see already interesting things around sample volume ranging from 1 to 10 mils based on the age of the patient. And you see that there are lots of facilities available to store these samples, centrifuge them, store them, ship them on dry ice, etc. And then you can see that at the time till analysis could be up to 6 months. And so that shows that this is clearly not a thing you can organize as a type of intervention. But finally, they found out that it was well absorbed, and even the lower exposures in patients did not result in reduced clearance of the parasite. So clearly, they have now evidence-based alternative route of administration to treat their most sick patients with malaria. I myself also had a little bit of experience in rural studies, and in this case, we're talking about Burundi ulcer disease, and this is caused by Mycobacterium ulcerans, and which causes devastating skin lesions caused by the toxin of the bacteria. And at that time, Ghana was one of the hotspots in the world. And my father-in-law was infectious diseases physician and was treating patients in that particular situation. And they were doing a clinical trial because the standard treatment of this disease would have been surgical treatment with skin grafting, which has not very successful outcomes because all the wound care and physical therapy afterwards is very limited in these settings. And so they looked at a more therapeutic type of approach without the need of the very toxic streptomycin, which was the standard antibiotic treatment at that time. And so they moved away from that to rifampicin, clarithromycin-based therapy. And while doing that study, the interim analysis, which you of course do in such a trial, proved that it was successful, that they continued with the trial. However, as a properly trained pharmacist, I noticed the drug-drug interaction in this trial between rifampicin and clarithromycin. So clearly there was a need to further investigate this drug-drug interaction. So what we did, that we performed a sub-study within the larger trial, looking at the different subgroups with either clarithromycin rifampicin-based therapy or rifampicin streptomycin-based therapy. And we found that the drug-drug interaction was significant. And we found that, for example, the clarithromycin to metabolite ratio was completely inversed. Also, clarithromycin boosted the rifampicin exposure, but we know nowadays that drug exposure to rifampicin can be high enough with dosages up to 40-45 milligrams per kilogram. So that was not our major concern. However, when we did this PK trial in rural setting, it was with traditional sampling. And so when I went back to my original manuscript, I found the sentence that people had to be able to return home in the evening after the sampling. So that was our explanation why we were not able to monitor these patients for 24 hours with PK sampling. And the other thing was the sample stability. And so if we look at rifampicin, which is a fairly unstable drug, so after 2 days, you already lost about 30% of the rifampicin in your sample. And at that time, there was no -80 freezer available on site. So we had to work with -20 and cold chain to our lab in the Netherlands, which was quite a challenging situation. However, the nightmare began when they decided to do a follow-up study with a higher dose of slow-release clarithromycin in an attempt to overcome this drug-drug interaction. So I envisioned already this was going to be a nightmare for a traditional PK sampling point of view. And so at that time, one of my PhD students considered developing a dried blood spot assay for this combination of drugs. And of course, we will look at standard items like accuracy and within run, between run precision, etc. But most interesting part for us was, of course, the sample stability. And particularly when we looked at rifampicin, we found that at ambient temperature, at 60 days, the results were quite okay. If we compare it to 48 hours in a standard blood sample. We also looked at higher temperatures because if the sample is in the sun or whatever, it can be a little bit warmer. And of course, that affected the stability of the sample, but still it was much more stable than in liquid condition. So when you want to assess your sample stability of your dried micro sample, you have to take into account a lot of conditions. So often people forget and only look at a stability assessment in the lab, and sometimes they indeed put it at higher temperature for a prolonged period. But you really have to mimic the extreme conditions that you can expect during your study or during shipment of your samples. Ideally, you could run a few real-time experiments where you ship your samples with predefined conditions through the whole transport chain and see what the results are. And then, of course, you have to do that again and again for the different sampling strategies you use. Could be either dry blood spot cards or Mitra tips or whatever you use. It can affect the stability of your sample. So after this first experiment, we tried to do a feasibility study across multiple sites. So we looked at Bangladesh, Belarus, Indonesia, and Paraguay, and provided the participants in this study with written instruction and a video, just in an attempt to see whether this was sufficient enough to train them in a way to produce samples. And when we got the samples, we assessed them based on 19 criteria with various aspects of integrity of the card, appropriate drying, and blood volume and blood spot, etc., etc. And now you can see a couple of examples at the bottom of this slide. And you can see that on the left, the circles are not perfectly round. In the middle, there is some hemolysis caused. Likely the cards were a little bit moist before the patients were sampled. You see ideal samples in the middle and some overlaying spots on the right. So all these different types of sample collection and performance of that procedure affect whether your sample is usable or not. So we looked at all these aspects from the different settings, and we found that depending on the settings, the affected procedures would either be related to collection, to storage, to procedures. And important to know is that at the end, if you take into account all these deviations, and that resulted that in Bangladesh, only 40% of the samples could be used for analysis. but in Indonesia, over 80% of the samples could be used. So it's about guaranteeing that your sample has sufficient quality, and different solutions are available. It could either be that the collection device has a fixed volume, that is part of the solution. You could have smartphone applications to assess the quality of your spot at the site of collection. So if it's not approved by the smartphone app, you can resample at that same time and not hear back from the lab a couple of weeks later that the sample was not correct. Now, we also looked at children because it was considered that pediatric sampling with dry blood spots could be of interest. In this case, we looked at children in Paraguay, and on the right side, you can see the Passing-Bablock regression fit versus the plasma concentration for, in this case, pyrazinamide, and that looked quite nice. And we sampled these patients over 4 hours, 4 time points over 8 hours to assess total drug exposure during the day. And we also looked at the facial pain scale, and you can see the drawings of the faces at the bottom of this slide. So when the samples were collected, pictures were taken of the children and separately rated by 3 observers. And you can see that the pain considered is substantial. The range is wide, 2 to 6, but the average was 5. So that is, I think, substantial. And that is part related to the fact that multiple samples were collected. The patients had to wait for a prolonged period, so that did not improve the tolerance to this procedure. And I think at least it gives me the idea that when you want to collect multiple samples during a day to collect a full PK curve, collecting each via dried blood spots through finger prick may not be the ideal solution. If you want to collect full PK curve, perhaps insert a cannula and still collect your samples through the traditional way, but store them on dry blood spot cards if traditional freezers or dry ice are not available. And so it's kind of a hybrid combination of traditional sampling with a cannula for multiple samples, but still use the benefit of your dried sample with the card. There are many studies nowadays comparing plasma and Mitra and dried blood spots, etc., to see which performs better. And when you assess these trials, it's important to have a little bit of a background on procedures, on options, and to better value the results as they are presented. I put on this slide a table where they compared Mitra versus DBS, and you see several items that they assessed, for example, the volume of the sample, shipment conditions, and then you see the need for a sampling aid, a glass capillary, and then they say yes for dry blood spot and no for Mitra. But it completely depends on how you perform your dry blood spot procedure. So you can use glass capillaries, but you can also use a falling drop of blood. In that case, DBS would be no, the same as for Mitra. And also some of these issues, whether you need a drying rack, yes or no. How relevant is that? I've seen pictures of people just sticking the dry blood spot card with a small corner in the clay wall of the cabin they were working in. And so some items are more relevant than others. Sample stability is very important. And what I would like to encourage people is please try to perform these stability experiments as long as possible, because you may end up in situations like earlier discussed in this talk, where samples were stored for over 6 months. So if you have then stored them for 2 months and you don't know what happens after that period, you're not completely happy to present those results. Indeed, costs is an issue. In this case, Mitra was more expensive than dry blood spot. I don't know how relevant that is for a study. It may be relevant for future clinical practice, but that is something that we will see in the future, how these techniques evolve. So high quality is important, and Christoph already mentioned our paper from the International Society of TDM and Toxicology, where we put a lot of effort in presenting all the strategies for analytical and clinical validation of microsampling. This paper was specifically focused on dry blood spot, but most of these items also apply for other dried sampling strategies. So it's important to realize that besides the standard procedures for validation, you also require additional aspects like volume, hematocrit, volcano effect, and all are nicely described how to assess them. Also important is before you actually move on to implementing your dry blood spot technique, that you have a proper clinical as well as analytical validation with the different collection procedures to be able to translate results collected from a dry blood spot to a reference plasma range. There's a lot of development in microsampling devices, and a few of them are shown on these screens, and these were nicely summarized by a PhD student of Christoph. And I think these are interesting, and depending on the situation, they can be used in remote PK studies, as long as you have a reference laboratory at your disposal to analyze the samples, because of course they still require LC-MS analysis. So when we are shifting gears from PK studies to TDM in remote settings, of course, the same situation applies. We lack the facilities, and resources are limited. What we have to realize is when we are performing a PK study and we have our results, that we want to do something with these results for the population affected by our findings. So we can either design studies in such a way that results can be easily translated in those changes, or that we can provide TDM solutions. And this is an example from Australia, where they looked at TDM of Posaconazole in a Wollongong hospital, and they showed that they had a turnaround time from 3 to 7 days when they sent the samples to Sydney. And of course, when you are a critically ill patient on the ICU, 7 days is not acceptable. So you want something that is faster. And of course, a dry blood spot cannot make it faster. So we have to look for alternatives. And especially if we're talking about remote settings, in less resourced situations, it needs to be affordable, simple, and ideally short turnaround and non-invasive. So we developed a technique using oral fluids and this mobile nanophotometer. And with this technique, we were able to quantify levofloxacin concentrations in patients with MDR-TB, and were able to identify patients with low drug exposure. Another technique presented uses urine, and in this case, they looked at rifampicin, and with a smartphone and a small box, they could quantify the absorption of the sample and relate that to rifampicin drug concentrations, and subsequently also to low exposure in plasma. So if we're talking about remote settings and TDM and PK studies, we're talking about measurements on site if we want to do TDM studies. We're talking about microsampling if we have the opportunity to send it either to a regional or central facility with appropriate equipment. And when we, of course, talk about interventions with TDM that are less urgent, then of course dried blood spot samples can be used because there is some time. But if we're talking about immediate interventions, then of course we need something that is available on the spot. And with that, I would like to conclude my presentation and happy to take any questions.
Thank you very much, Jan-Willem. That was an excellent talk, and I see you there at Westmead. I hope things are going okay within your hospital.
Yeah.
Now, again, people can pop questions on the Q&A if they like, but I'm going to start off because I've got a couple. The first one, I completely agree with you regarding stability testing and expanding that to as long as you possibly can. But I did just recently encounter, we were doing some testing on amoxicillin, and we found that it really wasn't stable as a dry blood spot across a few months. I think we tested it around 4 months. And I'm just wondering if you've seen or experienced where you don't have stability, but perhaps so it doesn't fit within the criteria of, say, 20% precision and accuracy, but that you do see consistent degradation, whether or not you're able to apply a correction to make it still a result of value. Is that anything you've encountered?
I have seen those situations, and indeed that is a challenge. And when you want to report such a result in a paper, I think you have to be transparent about it and say, okay, we have stability data up to 4 months. We extrapolated it based on degradation from month 6, and this is what it is.
Yep.
I would not recommend just calculating it and not mentioning it in your paper. Yeah, and ideally, yeah, sample stability is what it is, and if it doesn't comply with the criteria, we should discard the samples.
Yeah,
and I think it is about sample storage and analysis, and if you are aware of it, you can send these samples earlier and have them analyzed in batches. Particularly the shipment costs of these dried samples are very low compared to the dry ice shipments we did in the past.
And that's exactly the circumstance.
Yeah.
So the samples weren't local. They did need to come from a long distance, and we were actually just in touch with the group after the samples had been collected. So yeah, so it is a real challenge, but it's a real world challenge, isn't it?
Yeah, it is.
Yeah,
yes.
yeah. Okay, and so my other comment is about the study, because I've read that, and I noticed the pain study in the children where they registered a 5, and it's similar to what we've encountered in PK studies, and I think Tavia will discuss this in detail, but so we perform surveys, we ask parents and patients, how they feel about microsampling, but I think one of the things we miss is where patients might agree to a microsample for the first 2 or 3, and then you're in a PK study, so you need maybe 5, 6 samples, and towards the end, certainly the older pediatric patients are saying enough. Yeah.
Yeah, so in that case, putting in an intravenous cannula, it's only 1 prick, and you can sample these venously collected DBS samples and then just collect them. What I am interested in is how children are prepared for this type of sampling. I've seen this firsthand with COVID testing, because the nasal swab is not very pleasant for young children. And depending on how you prepare them for that sampling procedure, they're more acceptable to it than when they're not prepared, and they're frightened or scared when it happens. So I think if we can present the finger prick in such a way that they can relate to it, for example, you step on a block of Lego, it feels like that, or something else that they can relate to, perhaps the acceptance and pain is less. And that's perfect, because
ties immediately into my question with regard that study was, did you use or did you find effective the use of warming of the hand beforehand or ice afterwards to, myself, I've often, used multiple finger pricks in a day just to collect, drug-free samples. And yeah, I can tell you it hurts. But yeah, I was wondering if that was something you incorporated into the study or?
Yeah, so where we typically do indeed pre-warm fingers, but of course, when you are in Paraguay, they already warm compared to my previous situation in the Netherlands or even in Australia in winter. The treatment afterwards, I've not tried that before, but I think that's an interesting one.
Yeah. I guess it's availability of ice then, so as well. Yeah, so difficult in rural and remote regions. Okay. Well, thank you very much, Jan-Willem. If anyone's got any questions, Jan-Willem will be about, and we can also contact him by email.